Thank you, chairpersons. 3 minutes, yeah? 3 minutes, please. It's put 1.57, to begin with.
1 minute 57 seconds.
In fact, I will take only 1 minute to, to showcase my, point. Thank you. I think looking into a triple procedure, we have graduated to endothelial keratoplasty in Fuchs. These are certain points I like to define my way of doing DSAEK triple in these cases. Patient selection-wise, looking into various stages of Fuchs dystrophy, in India we see sometimes patients very, very late, where things can be very thick corneas, hazy corneas, where DMAEK sometimes may not be good choice. The DSAEK would overscore in those situations as such. Donor preparation is a major challenge for us. We all are doing endothelial keratoplasty. We know that DSAEK preparation, donor preparation is much, much safer, easier for us. Looking into a microkeratome-assisted preparation of donor tissue gives a very, very nice ultra-thin DSAEK lenticule, which is as good as DMAEK preparation. That for donor age, you require less than 50 years age of patient in DMAEK, where you have a compromised age and endothelial cells, while no limit for DSAEK surgery. You can have even a 1-year-old child also with a huge endothelial cells. Tissue loss, which is a major concern. See here various studies. Tosef et al. 16% tissue loss, and Price et al. 8% tissue loss. That's a huge number of tissue loss happening in a country like ours, where you have a scarcity of good endothelial tissue for us. And if you imagine 2.1% ultra-thin DSAEK, which is a little on the higher side from Francis Price, otherwise in our hand is 0%. Next is the endothelial cell loss preparation of donor tissue, which we know that DSAEK will have very, very controlled less tissue cell loss, which ranges around 1 to 2%, in ultra-thin less than 5%, while DMAEK can range from 4% to 83%, sometimes total loss of tissue also. So these are two major concerns for me to look into a patient coming for endothelial keratoplasty. Learning curve for us, like we have graduated to a DSAEK in a manner we could do it very fast and easy without causing damage. DMAEK is still evolving. Many patients find a lot of challenges there. There is a higher chance of graft dislocation and rebubbling in DMAEK cases, which ranges from 4% to almost 15% in those cases. Visual outcomes, yes, DMAEK will give slightly rapid recovery, but ultra-thin DSAEK overscores all the challenges of conventional DSAEK. I have series where we have very good results in these cases. Anatomically, the major challenge is the primary donor failure, which is much more in a DMAEK cases than DSAEK. DSAEK is well-controlled surgery for us. This is one area, graft rejection, which is less in the DMAEK, more in a DSAEK patient, but conventional DSAEK and DMAEK ultra-thin DSAEK is different issue here. So I would say suitable technique for all type of endothelial keratoplasty, holds true for Fuchs also, easy, safe, and the dislocation primary failure is less with the DSAEK. Therefore, I would go for a DSAEK surgery, because DMAEK is not for all cases, not for all surgeons, and DSAEK is universally acceptable to all surgeons who are doing primary endothelial keratoplasty with cataract. I think with Fuchs, I'll go for a DSAEK triple in my